It's a great question. Some of the biggest early hurdles are practical, trying to get clinic space and scheduling templates built in the electronic medical record, making sure that everyone understands who the model is for. That our referring pediatricians are referring the right patients to this clinic, and that they understand that in this model, it is a consultative model. And so we expect that the patients, as appropriate and for the most part, are going to be able to go back to their general pediatrics practice after they're seen in this clinic for several to, a dozen visits. Um, One other piece that was really important to get in place was the billing and funding of this, which we'll get to a little bit later in the questions as well. But making sure that that's aligned was really important. And also having a consistent structure for our trainees. So getting dedicated trainee time to be able to consistently staff the clinic every week and have, two pediatrics residents in the clinic to be able to see these patients so that there was consistency in the care. But I think the biggest thing was being explicit about the scope and the types of patients that we're going to be able to see. And I think the way that we overcame these barriers was by really good communication. So we had a great collaboration between our child and adolescent psychiatrist and between the general pediatricians. We invited our child and adolescent psychiatrist to come to some of our general pediatrics faculty meetings to talk about this partnership at the onset. We initially had a social worker that was able to help do some screening to make sure that the referrals were appropriate. Eventually, that position was eliminated, but the culture of having the appropriate patients referred was there. And then we also have had a really strong tie between the pediatrics residency program and the child and adolescent psychiatrist who's running the program, and have frequent check-ins to make sure that we are still aligned with meeting the goals and objectives of both what's needed from a patient care standpoint as well as the educational needs for our pediatrics residents. When thinking about how to transition patients back to their primary care physician, our child and adolescent psychiatrist, who's the senior author on our paper, Dr. Quigley, will look at the individual case and really determine this on a case-by-case basis. There are, as the child and adolescent psychiatrist gets to know the patient and gets an understanding of their mental health condition and the severity, they either start to formulate a plan of transitioning them back to their primary care physician or to a psychiatrist in the community that can do more long-term care. To be able to transfer back to a primary care physician, there's a couple of things that need to be in place. One is a couple of months of stability on their current medication regimen. Two is making sure that the physician who's going to be taking over care, the primary care physician, feels comfortable with the management plan. So having that warm handoff and EMR communication to help figure out when a patient is ready to go back to their primary care doctor is really crucial to this process. That's a great question. This clinic model was really intentionally built to both increase access now for our patients. We have two residents scheduled in a staff model with our child and adolescent psychiatrists. So they're able to see a good number of patients over the course of the half day. And in that staff model, the residents are able to use their clinical skills to obtain a history, and then the child and adolescent psychiatrist can really provide that training in, both historical questions of, things that the resident might have missed, but especially that management piece and really helping them think about how to think like a psychiatrist, and how a child and adolescent psychiatrist approaches this. And that gets into the clinic model and the training model's long-term effects. Our hope is that embedding this training in pediatrics residency training, residents will then be able to have a better capacity to care for these patients once they graduate. So we're not only getting patients in and having them be seen in the moment, but we're also growing the pediatric workforce as far as their comfort in managing mental health conditions. So in our model, billing and reimbursement for the visit flows to the psychiatry department. So the work RVUs for patients that are being seen flow to the psychiatry department and help cover the child psychiatrist's effort to staff the clinic. So that funds flow allows for us to have that valuable expertise of the child and adolescent psychiatrist embedded in our primary care practice. We also have made sure to make this very consistent and kind of bite off what we can chew. This is not a full FTE effort of a child and adolescent psychiatrist. This is, a small percentage. And I would say, start small. See if you can get, someone to come into your clinic for a half day a week and see the patients that you're able to see if the number of patients you're able to funnel toward them can meet the needs to pay for that service from the child and adolescent psychiatrist. Our model is a trainee model, and that works really well for us because we're able to have multiple resident staff with the child and adolescent psychiatrist. And I think there are many clinics in more rural areas that also have rotating residents or maybe even other practice providers that could work in a similar model.